All right, you
Welcome
ready for me?
everyone to Gilda's Club's pain management class in conjunction with Dr. William Rosenberg and the Center for the Relief of Pain. We're so thrilled to have you all here tonight, and thank you, Dr. Rosenberg, for being here with us. We really appreciate the time that you're giving to us. So I'm going to turn it over to you and let you go on from here. Thank you.
Thank you. Thank you for having me. I'm Bill Rosenberg. I'm a neurosurgeon, and I started the Center for the Relief of Pain a number of years ago. I specialize in spine surgery and pain surgery, and neurosurgery is very involved in pain. A lot of people don't know that. While you see my disclosures there, I'll tell you a little bit of background about me. I started off as a spine surgeon. I've spent my whole career as a spine surgeon, and about 15 years ago, decided that I was very interested in pain, and a lot of that came as either with cancer diagnosis or as a consequence of treatment, as we'll see. And so I started to become very involved in pain neurosurgery in addition to spine neurosurgery. I started the Center for the Relief of Pain, and I'm actually not a pain doctor. I interface with pain doctors quite a bit and try to present a multidisciplinary approach to the issue of pain, and specifically cancer-related pain. If we look at cancer-related pain, about 2/3 of it comes from tumor itself, tumor involvement with the surrounding structures, pressure, things like that. About 1/4 of it comes as a result of the things we do to treat the cancer: radiation, chemotherapy, surgery. And about 1 in 10, are other diagnoses that are not related to cancer that occur in patients who have cancer, herniated discs, things like this. Most of the pain that we deal with is what's called a mixed type, that pain really comes in a couple of different varieties. There's this, what we call somatic or nociceptive pain, which is the pain of a broken leg, of a cut. There's visceral pain, which is the pain of the abdomen, liver, things like that. And neuropathic pain, which is the pain caused by damaged nerves or sick nerves that is no longer a response to an actual injury, but is a phenomenon of itself caused by the actual damaged nerve. And those have very different treatment consequences. In terms of the epidemiology, about half of cancer patients who are undergoing treatment will have significant pain, and 90% of those with advanced cancer will have significant pain. It's the third most common symptom, and it's often the most feared. And I don't have to tell the people here, it's a big problem, and often one that's inadequately recognized and treated by healthcare providers. Oncologists have very busy jobs and have to deal with a lot of different things of counts and chemotherapy and side effects and what have you, but oftentimes pain doesn't get the attention that it needs, or the kind of attention that actually might result in a real benefit to that pain. And we know from studies, you'll see the last line on the slide, that not only is it a quality of life issue in terms of pain control, but pain control actually is associated with improved survival and outcome. When we look at a cancer pain patient, it's fundamentally the same as what we look at any pain patient. We have to take a step back and not make any assumptions, and look at the big picture of what's causing the pain, what kind of pain. We talked about a mixed type of pain. What are the goals? What's the prognosis? What do we need to achieve in terms of treatment, chemotherapy, physical therapy? Where do people want to be? How do they envision this journey? And how do we help them control the pain as best we can along that? Fundamentally, we can do a few things, and we do them in a lot of different ways. We can change the source of the pain. We can, in other words, surgery. We can take out a tumor if it's causing pain, and sometimes that can help with pain. We can change the transmission. We'll talk about various ways we can do that with modifying how nerves transmit pain. We can change the central perception, the things, anything from medications like the opioids and other medications to some of the things I do as a neurosurgeon can change how that pain is centrally processed. And fundamentally, though, we need to approach pain as a team. It's not any one person, provider. There's a lot of different factors that come into play, and it's not just having a hammer and looking for a nail. We need to integrate all of these things. And I actually started a 501c3 called the Cancer Pain Research Consortium a number of years ago, and the goal is to bring all of these different disciplines under one roof to have a discussion of how do we integrate, how do we figure out what order to do things in, all in the service of getting the patient the best pain control possible. Many people are surprised that neurosurgery has a role in pain control. But it actually is a very ancient one or long-standing one. And it starts way back in the Middle Ages with, before there were anything called a neurosurgeon, where battlefield surgeons would cut nerves to relieve pain. Turned out that's a poor strategy. But you can see there, over the years, we have had a number of procedures that deal with pain in neurosurgery. And it was only more recently with the advent of opioids in the late 1800s and early 1900s that neurosurgeons sort of took a step back. We all thought that that was the solution. The anesthesiologist took over, and we're only more recently learning that that might not be the whole story, and maybe we should be, again, a little bit more involved. But we do have actually a very big neurosurgical toolbox when it comes to pain. We can basically divide it into changing the way the nervous system processes pain, what we call neuromodulation, versus neuroablation, where we actually change or modify or basically turn off various parts of the nervous system to control pain. Those are the two basic areas. And within the neuromodulation or changing, we can do it in two big ways. We can targeted drug delivery is delivering microscopic doses of some standard medications like morphine or some non-standard medications like local anesthetics directly to the nervous system, which we can avoid a lot of the side effects. We can be more effective. We can provide more control. We're going to talk about that. Another big area of changing how the nervous system processes is what's called neurostimulation, where we know we can apply a small electrical current to various parts of the nervous system and actually improve certain types of pain, mostly nerve pain. So to delve into that, the first is targeted drug delivery, and many people know of this as the pain pump. And this is really our workhorse in trying to control cancer-related pain. We can use this for really any regional severe pain. It's very difficult to get whole body control, and we'll talk about that in some subsequent slides. But if it's the lower extremities, an arm, the abdomen, the back, it can be very, very good. And it really, the way it really shines is we can avoid some of the unacceptable systemic toxicities of the opioids, the nausea, the loss of appetite, the lethargy, things like that. None of those side effects occur if we're delivering very, very tiny amounts of these medications directly to the spinal cord. We also can use this if we think there may be very severe pain coming down the road at some point. We can put this in, get it all healed and nice, no infection, things like that. And then we have a tool. We can try different medications and change them out. We can provide the patient with looks like a little garage door opener. but it allows dosing within limits to take care of sudden increases in pain. But it gives us a lot of a very powerful tool to keep, basically our goal at the Center for the Relief of Pain is to keep the patient comfortable with limited side effects, out of the hospital, out of the emergency room. That's the goal. And the other nice thing is it's reversible. If there comes a point where the pain pump's no longer needed, we can just take it out. So this is one of our strong workhorses with cancer pain. It's a small procedure, an outpatient or overnight procedure done under usually general anesthesia. It takes 30, 45 minutes. There's a small incision in the back where we do a spinal tap and put in the catheter, and a slightly bigger incision, but just through the skin somewhere else, usually the abdomen, depends on other issues, where we put the pump in under the skin, and it's hooked up under the skin. And there's risks to everything, but the risks are very low. Basically infection, some mechanical failures, or a spinal fluid leak. But it is MRI compatible, so it doesn't interfere with any imaging or radiation or anything like that. We do need to consider radiation, and we work carefully with the radiation oncologist for ports and things. We do put it in with chemotherapy, although there is a certain type of chemotherapy called angiogenesis inhibitors, where we can't put it in because of wound healing. We have to have a window that we coordinate with the medical oncologist. We need a brief window off of anticoagulation, and any kind of ongoing infection gives us pause. It's not an absolute contraindication. But this has a lot of peer-reviewed. This study is a randomized, multi-center trial where they found actually a big advantage in pain control and an even greater advantage in toxicity in terms of side effects. And this actually was the first study to lead us to think there might be a survival advantage. And that subsequently there have been several other studies that have looked at this. And this last is a group that I participated in where we came out with guidelines, and now there are pretty accepted guidelines that for this kind of pain control. And I think it would be nice if people knew this were an option if they are suffering from severe pain, or their providers are anticipating the possibility of severe pain, and we work hard to try to get the word out to the medical oncologists. These are some of my patients. Again, these are all with permission. And you can read, this is a woman with pancreatic cancer, and her dream was to go to Hawaii, and we got her there. And she had a great outcome. Another woman with vulvar cancer, horrible pain. Again, she really benefited from having a pain pump, and we have literally dozens of these stories. To move to the other form of how we change the way the nervous system processes pain is stimulation. That's applying a small electrical current to various parts, and we can apply it to the spinal cord. That's the usual. We can apply it to peripheral nerve. We can even apply it to the deep brain structures. It's most effective with that neuropathic pain, the pain that's caused by damaged or sick nerves that are sending erroneous pain signals to the brain. And this is an example of spinal cord stimulation. This is done with a couple of needles, epidural needles, like are used for anesthesia for pregnancy, or for epidural steroid injections. But you can see, as instead of medicine, we wiggle this little wire called a lead up under X-ray guidance to a certain spot next to the spinal cord. We turn it on, people feel it, it's a pleasant feeling. And again, we can get regional control, the legs, the arms, but we can't get total body coverage. And again, this is good for damaged or sick nerves. These are some examples of peripheral nerve stimulation, and it's hard to see here, but this is on the median nerve here, and this is for a man had inguinal surgery and severe nerve pain. And you can see here, this is a prosthesis. So this person had an amputation, had very bad pain to the point he could not wear his prosthesis. And right here, you can see a sciatic nerve paddle where we got enough control. He's standing in his prosthesis for the first time for this x-ray. And this is, you can see here an orthopedic screw. This is severe knee pain. This is not for cancer. This is actually a sports injury. But you can see these leads are under the skin, and we're controlling this knee pain with that application of electricity. And this is an example of deep brain stimulation. If nothing else works, or if it's an area we can't reach, like the face, then we can put leads in the brain. We do this awake, actually, with the patient telling us where they feel it. Very well tolerated. It's a small burr, what's called a burr hole. And we have some great success with this. Now, in terms of how it's related to cancer, it's two ways. Mostly it's in controlling that 25% that have symptoms as a consequence of what we do, chemotherapy, radiation, surgery. Sometimes those things damage nerves, and they can be painful. Somebody who's had a thoracotomy can have damaged nerves with thoracotomy pain, or mastectomy can have significant pain, or radiation. So we can use those things, spinal cord stimulation, peripheral nerve stimulation, to help control that pain very successfully. Excuse me. In a different scenario, if we have an active tumor, but it involves the nerve to such an extent that the dominant pain is nerve pain. I had a patient, and this is described here, I had a patient who had prostate cancer, and it was involving the pelvis, and we had a pain pump in, and we were getting very good control until the tumor involved the sciatic nerve, and that caused really bad nerve pain. And we were going up and up and up and up on the pump, and that was really driving how we were managing things. So what we did is we put in a stimulator, a spinal cord stimulator, got control of the nerve pain. We were able to come down on the medication in the pump, and that way, in combination, we were able to get better pain control. And there's, again, a big peer-reviewed literature, particularly chemotherapy-induced nerve pain. This is very effective. Post-thoracotomy pain, such as this, it is a good option to know about. And there's even some, this is part of Cochrane systemic reviews, where they look, systematic reviews, where they look at the entirety of the literature. And there isn't a huge amount of literature for any of these. In most of neurosurgery, there isn't. But they did find that there was an advantage in the literature that does exist. And this is a poster I published with the North American Neuromodulation Society a couple years ago. And this was a man who had a oral facial tumor with radiation. That was successfully treated as tumor, but it damaged the brainstem and gave him nerve pain. And we actually were able to get control of his nerve pain with these two different places we put the leads, one high and one low, to get control of one half of his body where the pain was distributed. In terms of neuroablation, that's the other side, where we actually change the nervous system and how it processes pain. Don't worry, I'm not going to go through every one of these, but we have a lot of different things in this toolbox from a neurosurgical standpoint. I am going to highlight a couple of them because they can very dramatically impact pain control. And the first one I'm going to talk about is what's called chordotomy. Excuse me. And this is, you can see the diagram there on the right. It's done awake as an outpatient under local anesthetic in the CT scanner. We put a needle right here after numbing it up. And we go with a probe, we find the pain fibers in the spinal cord and we turn them off. Just the pain fibers, not the motor fibers, not other sensation, just pain. So we do what's called a myelogram. The radiologist will put in some dye through a spinal tap. That helps us see. We go to the CAT scanner. We numb this area up. We put in the needle and we identify. And by identify, it means that actually the patient, we talk to the patient, we stimulate and say, yeah, I feel a warm or a buzzing sensation on some area of the body that's close to what hurts. And 3 minutes later, we're done. And a couple hours later, they go home. It is very, very effective for pain almost anywhere from the shoulder down. Up here is more, we can't get in this approach. There are other approaches, but from the shoulder down, for chest wall involvement, for pelvis, this is what it looks like in the CAT scanner. And you can see here's the nose is here and the back of the head is here. And this is the C12. This is at the very base of the skull. The jaw is here. And this is the spinal cord floating in spinal fluid that is dye filled, the myelogram. And the needle is coming here, and you can see the probe just getting into the spinal cord here. And that's the area where the pain fibers are right there. And that's what it looks like. The major issue with this, and the reason why we don't use it for any pain, is because there's always been a question of how long it lasts. The neurosurgery board's answer is 2 years. We usually can get at least 2 years out of this. It can be repeated. So there's that. But the fact is that we really haven't had an opportunity to study this modern technique. There's an older one that we don't use anymore. This modern technique with modern scientific methods. And the fact is that there are case reports, this is written by a friend of mine, Dr. Patil in Michigan, where, I mean, this patient just came back after 40 years wanting to have it done again. So it's unclear. Easy to do, low risk, and can be very effective. And we do have some good data on this. This is several hundred, a couple hundred patients, probably the biggest study, and it is very, very effective. And here's an example, and this is one of my patients. His name was Steve. And he had this large tumor. He discovered it out of the blue. It was a synovial cell sarcoma of the femur. You can see it here on the MRI scan. And he had just severe pain. He couldn't walk. He was inoperable. He wore a brace and he only got out of bed to go to physicians. And he was on a continuous Dilaudid drip. And we talked about his goals and talked about a pump, and we decided to do a cordotomy. And it was instantaneous. He walked out of the hospital from the cordotomy. Really dramatic. And that is often the case. To shift tack a little bit, there's another similar type of thing called a midline myelotomy. Again, it's interrupting pain fibers, but these are the pain fibers from the abdomen, the viscera, liver, pancreas, pelvis, sacrum. So different pain fibers than those ones that we showed. And this is a different approach, but the same kind of thing, a midline myelotomy. This has two different varieties. There's an open, where we do a small surgery, and a percutaneous with a needle. Any pain in the abdomen, so that would involve liver, ovarian cancer, pancreatic cancer, cancer involving the sacrum, any of that. And there are some of these, you can read there are some risks. They're all very low. And to be honest, the only one of those I've seen in my patients is urinary retention. That can happen where it's hard to urinate, and that usually subsides after a little while, but that can happen. I've not seen the others. JPS is joint position sense. And this is the open variety. This is through the operating microscope. So this whole thing here is the spinal cord, and this width here is about the width of your thumb. And what we've done is we've identified this is the posterior, the back surface of the spinal cord. This is an instrument that's interrupting these fibers here. This is a suction device. So that's how it looks under the operating microscope. There are less data for this, but still data. And the effect seems to be very robust. Same kind of thing. We know to 2 years, we're not sure beyond that. We're not sure yet about which is most effective, whether the small surgery or the needle. This is what the needle looks like. So you can see this a little different. The nose is down here and the back of the head is here. And this is the spinal cord, a little higher up, but at the base of the skull. And you can see the probe coming in from the back, and this is coming right into the middle there. And that's where we make our lesion, where we turn those fibers off. And you can see, so this is a woman who had recurrent pancreatic cancer. This is how we measure opioids. These are called morphine equivalents. So she was on basically the equivalent of 180 to 300 milligrams of morphine a day. And we did this. And over the course of a week, that went down to 10 to 20 milligrams morphine equivalent a day, and with better pain control. So again, then this is an outpatient procedure. Obviously, the surgery is a short inpatient stay. Another thing we can do is interrupt the pain fibers as they come into the spinal cord. This is often done for arm pain. So for tumors that involve the top of the lung, called a Pancoast tumor, or for invasion into what's called the brachial plexus, which are all the nerves that come out of the neck and go into the arm, or if there's radiation to the hair, oftentimes it's in the port of a breast tumor that causes a plexopathy, what's called a plexopathy of that plexus. If that's severely painful, we can do this if there's not function in the arm. If there's still function in the arm, we have different approaches, but if there isn't, this is a very good approach. And this is how that looks in the operating room. Here's the spinal cord again, but now we're off on the side here. We're finding these little areas that the nerves come in. It's hard to see in this picture, but you can see we're kind of developing this line going down here where we're lesioning those and taking care of that pain. And this is for facial pain. We're fortunate because with the face, the fibers enter through the trigeminal nerve, sensory fibers enter through the trigeminal, but the pain fibers by themselves dive down toward the brainstem where we get access to them. The motor fibers and the regular sensory fibers go upward. So we take advantage of this and we can catch those fibers here and actually turn them off like we did before. And that can provide excellent pain relief for facial pain, for tumors of the face, the tongue, the palate, things like that can be, and we can do this open and we can do this percutaneously. This is the open procedure called big name nucleus caudalis DRES. This is the brainstem. This is higher. The spinal cord's down here, brainstem's up here, and this is our probe coming down here to turn those fibers off. The percutaneous, that with the needle, is obviously not as big as this. And here's a picture of that. So this is a woman who had glossopharyngeal cancer. She was unable to eat or drink because of pain. And so you can see here, this is the needle coming in. The black probe is coming through it, and this is the surface of the brainstem. What we're looking at is this surface right here at the base of the skull. This needle is coming in, and it's puncturing the brainstem right there. We create a lesion, and she was then able to eat and drink, was able to be discharged from the hospital. This is done asleep. So that's another option that we have. Only a couple more. This is called a hypophysectomy. That's the pituitary gland. And we actually used to do an open surgery to take that out. Now we can do it with what's called radiosurgery, which is an outpatient, non-invasive. We use a bunch of small beams of radiation to basically take out the pituitary. We actually don't know why it works, but it works very well for diffuse cancer pain. So this is like with bony metastases in a lot of different places or other diffuse cancer pain. No longer are we restricted to just an arm or a leg, but multiple sites. And it's very well tolerated. This is a patient of mine who's 80. He had widely metastatic prostate. You can see some of it here, but he had it really from his skull to his knees. He was over 500 milligram morphine equivalents per day and still had 10 out of 10 pain. And we did a single session. He came in, it was one morning, we did a single session. He went home, had lunch, and over the following several days, his pain, he went from 500 milligrams a day to 200 milligrams, but his pain went from a 10 out of 10 to a 2 out of 10, just from that one treatment. And this is his planning. This is how it, with all the multiple beams of radiation that all meet right here at the pituitary. This is a cingulotomy, which is very interesting. It's an area that you can see the purple right here. And this is the area called the limbic system, which has to do with emotion. And when we study this carefully, it actually turns out that it seems to affect more suffering than actual pain. And people might say, it's very interesting. People will say, yeah, it does hurt, but it just doesn't bother me quite as much. And there have been some small series of this, and there actually was one case report with air hunger. So sometimes when people have bad lung problems or a tumor of the lungs and they're just having a hard time catching their breath, there was one case report where this was very helpful. And this is for diffuse pain really anywhere and anywhere. And this is what that looks like on an MRI scan. These are two lesions that we do through very, very tiny holes, one on each side, brief anesthetic. And we use a computer to guide us exactly where we go with that. And just to, not to go through all the details, but these are just some common scenarios and the extent of the different options that we have. You can see the various things we can do for pancreatic cancer pain. And I think this ties into what I'm going to conclude, and I'll say it then, I'll say it now, that I just feel strongly that everyone deserves to have someone, some provider, thinking continuously, repetitively, can we get better pain control if there is uncontrolled pain? Because there are always different things to consider, options, and we need to be thinking about those. It's not just try this, and if this, it's nothing. This is for head and neck, and we have the pump, we have the percutaneous nucleotractotomy up here where we saw the open one, placing a drug delivery catheter through a small hole into the ventricle of the brain, which I didn't address here. That's cingulotomy. All of those could be options for that. This is for diffuse metastases. We have, again, depending on where the pain is, but we could use a drug pump. We could use that hypophysectomy, cingulotomy. So these are all possibilities, and as we go through the journey, they may be, we might use one, we might add another. It's not just one size fits all. This is another scenario of arm pain. This is just an example of how we can it's a journey, and we don't just do one thing and that's it. So 71-year-old man, you can read, there came in with a lung tumor at the top of his lung, and it had a metastasis. You can see on the MRI scan, this is the spine, tailbone's down here. This is a little metastasis here, and then this is a metastasis in the sacrum, the very bottom bone of the spine. It's replaced here. And he had bad chest pain, and he also had bad weight-bearing pain from this sacral metastasis. We put in a pain pump, and we got excellent control of this pain up here. But no matter what we did, we could not get control of the weight-bearing pain here. He was still in bed, and either sitting or standing was still very bad pain no matter what we did with the pump. So what we did is we did that small myelotomy through a small incision. You can actually see here, we opened up, this is the catheter of the pain pump going by the spinal cord. We moved this aside, We did the myelotomy, and then we closed things up. And then he was immediately able to sit up. He could ambulate. And after 2 months of being in the hospital and trying to get his pain under control, we got him out within a week of surgery. We're using both of those techniques. And we actually, some colleagues of mine and I got together and we combined cases, and we wrote up this kind of approach of using multiple different approaches to get the whole picture, which is pain relief. So obviously, I don't think that anybody here needs to know that it's important. It's important for quality of life. We think that the possible impact on survival might have many reasons, but one of them is being able to go to treatment, go to chemotherapy, go to physical therapy, get out of bed, take a walk. All of those things are far easier if you're not miserable with pain. There are many options, and those options can always be considered and reconsidered as things change during the cancer journey, and they're adaptable. People, for a pain pump might be the right solution for somebody, a cordotomy might be the right solution for somebody else, given the exact same scenario. But I do think it's important for patients to have an ongoing consideration, some provider, ongoing consideration for the best pain control with acceptable side effects. I think that's the key, is that it's very easy to give more and more and more of a drug. And if, the side effects are just whatever, they're lethargic or can't eat or vomiting, whatever, that's not acceptable. We need acceptable side effects, and we can do that if we think broadly and continuously. So that's all I have, and I'm happy to answer any questions.